So it was a very busy day today, and we had a lot of information coming from various fields. And so we begin first with Hep B. So it's quite unusual for this PHC. Hep C is not anymore there, so now we are talking about Hep B. And the first session was on therapy of hepatitis B and HBV suppressions. So the first talk was given by Sim-Jin Lee about the guidelines, and that's the guidelines that are currently available worldwide, with a slight difference between guidelines. And what is stressed is that the fact of making guidelines now is becoming more and more difficult because the rule and the techniques of making guidelines become more and more complex. And so I don't know if it's going to increase the durations of making a guideline. I don't know if it's going to increase the validity of this guideline. So also altogether, there is some difference between AASLD, EASL, APASL, and WHO guideline. But in general, they are in agreement. But in fact, when you look at the populations, we find some different number of in which the patients are or needs to be treated. In the future, the risk calculator may simplify selections of patients suitable for therapy. And of course, the goal of current guideline is to reduce disease progressions and mortality, as the likelihood of cure is low. But this may change in the future when we can achieve a functional cure more often. The next talk was very interesting, given by Thomas Berg, about the new tools that now we can use and how these tools, the new markers of HBV, and how these new markers can help us to take decisions, especially in patients who are now attainable for partial functional cure. And so now this new biomarker can give us a more refined characterizations of the activity and the infections and the risk for adverse outcome. And clearly, he stressed about all the data that we have about the evaluations of HB core antigens related, HBV RNA, low HBs antigens titer, the large HBs antigens particle or the medium HBs antigens particles, and also the low anti-HBC titer. And what is interesting is that if we follow these patients, maybe we can characterize a part of our populations with partial cure that can have a long, safe follow-up until we are able to achieve a complex functional cure. So that was very interesting. The next talk was given by Maria Buti about the optimal management of chronic hepatitis B under NUC. And of course, we need to do a proper assessments before starting therapy. We need to select the most appropriate NUC for treatment, especially in special populations. We think to switch from a TDF to TAF when patients are at risk factor, but in fact, that represents a very small proportions of our patients. And of course, the most important thing is we need to do an adequate HCC surveillance regardless of the type of the NUC that we use. And concerning the final point, which is, can we able to stop the therapy? Is there any possibility of finite therapy durations? And I think that we have to keep this in relations with the previous talk given by Thomas Berg. And I think that by using new tools, we can maybe select more appropriately the patients who can stop the treatments and get benefit of stopping treatment. Then we move to the state-of-art lecture about the new EASL recommendations for the management of occupational liver disease. And I think we need to thank Massimo for this wonderful work. It's the first EASL is the first recommendations on the management of occupational liver disease. AASLD have never done it, and neither the APASL. And so that's a very challenging task. And what he demonstrates to us is that the diagnosis of this occupational liver disease is very complex. It's have the range of all HBV liver disease, and it's very complex to make the diagnosis of such disease. The most important thing is to collect the occupational history, and which is crucial. And so we need to make time to collect this history, and patients must be assessed by a multidisciplinary team. Acute liver disease is rare compared to chronic liver disease injury, and there are many sensitizing factors. Of course, he focused most of his talk on the most severe disease, and especially liver angiocarcinoma, which is clearly associated with the high exposure to vinyl chloride in the past only. HCC is possible in this population, and cirrhosis is unlikely. So, and it also talk about other chemicals that can be involved into HCC. Hepatitis and cholestasis are the more dominant occupational lesions, often obscured by comorbidities such as alcohol and metabolic statosis. Of course, the unmet need is the availability of specific tests of toxicity. And of course, the future research may focus on the fact that we need to constitute a registry of collecting core data from all occupational exposure patients, including clinical, biochemical, and follow-up informations, in order to obtain an incidence figure in hepatotoxicity and train in re-emerging occupational liver disease. The development of quantifications of sensitive and specific biomarkers of liver damage caused by toxicant may help in fine-tuning of differential diagnosis, and without the need for histological examinations of the liver, which is currently the only things we have, and could also provide clue to prognosis. An advance in the field of biomarkers will allow more effective risk stratifications algorithm, will provide mechanistic insight that will help the development of safe and effective treatment. Then we move to the clinical case, and MIT give us an approach to patients with chronic Hep B and decompensated cirrhosis, and he gave us about two kinds of patients. The first kind of patients is patients who are HBV unknown or HBV known but not being treated. And these patients had a chronic progressions to active HBV or HBV flare as a result of either HBe seroconversions, treatment of HCV also, cancer chemotherapy, treatment of immune disease with high-dose corticosteroid, calcineurin inhibitors, and biological agents. And in this case, what we need to do is to start or restart oral HBV treatments, stop the inciting agents, of course, chemotherapy, immune suppressive agents, or PEG, and consider for transplants if liver functions do not improve. The second cases was patients who were HBV inactive or HBV suppressed on treatment and who had a progressions of another liver disease, such as acute alcoholic hepatitis, acute non-HBV hepatitis, or drug-induced liver injury like cancer chemotherapy or checkpoint inhibitor. And in this case, we need to treat or continue treating HBV, treat, of course, the inciting agents, stop the inciting agents if possible, and consider for transplant if liver functions did not improve. Then we move to the second sessions on Hep B. That's the sessions on therapy of hepatitis B tomorrow. So the first talk was given by Fabien Zulim on can we cure HBV with novel direct antiviral. It gives us a very nice overview of all the ongoing study and the published study. And clearly, what is stressed is that the fact with pre- and post-CCC DNA targets, we are going to accelerate the kinetics of CCC DNA decay. Combination therapy is likely required, and the durations of treatments will depend on the rate of hepatocyte turnover, and the major issue will be CCC DNA half-life, number of infected cells, and infected hepatocyte half-life. If you look to the direct targeting of cccDNA, which is cytokine-mediated degradations, nuclease-based genes editing or small molecule, there is still a long way to go. And specificity, safety profile, delivery issue is a whole kind of issue that need to be solved. By the end, the problem is that with all these agents, will this be sufficient, or do we need to have a combinations with immunomodulatory approach? And then Massimo Levrero, not Colombo, gave us a very nice talk given by not an immunologist, but a nearby immunologist, about how we can boost innate and adaptive immunity for HBV cure. So Massimo reminds us all what's happened about innate and adaptive immunity in HBV. And by the end, he showed that there is multiple approach aimed to activate the intrahepatic innate immunity and to restore the HBV-specific adaptive immunity. And these studies are currently ongoing. However, currently, interferon alpha remains maybe the only therapy that increases functional cure so far. So why immunotherapy didn't work so far? And here he gives us a very nice insight with a very recent paper. And clearly, immunotherapy could be an important asset for HBV cure, but patient selection is crucial. And immunotherapy needs to be personalized in relation with both immune profile of the disease and not only virological parameter, and also with the patient's specificity. By the end, Geoffrey gives the evidence that we will need novel combinations to cure HBV. And clearly, there is synergistic mechanisms needs to incorporate a decrease in HBV transcription, loss of cccDNA, or alter epigenetic regulations of cccDNA, and immune modulations or immunologically stimulated hepatocyte cells turnover. Nucleoside analogs suppress patients being included in many current trials. Trials are progressive to combinations therapy as additive or synergistic effects are thought. And those trials will provide important insight into the biology of HBV and perturbations of the immune response and require to affect HBs antigen loss at different stages of the disease. And after the discussions, one thing emerged from the panel discussion is that maybe we need to think about sequential use of this different therapy over time in order to achieve our goal. Then we move to the state-of-the-art lecture about HEP-E. What is the real issue of HEP-E? Of course, the incidence is high and rising. There is maybe a role of subtype, and subtype like genotype 3F might be associated with more aggressive disease. There is a risk of transmissions by transfusion, and currently most of the European nations have implemented hepatitis E screening among blood donors. Of course, neurological disorders are frequent with HEP-E, and they think that maybe these populations need to be treated with ribavirin even very early in order to improve also the neurological disorder. Treatment of acute HEP-E with ribavirin in immunocompetent patients is an issue, and I think that Jean-Marie showed the data that they have published, suggesting that at least in patients who have quite advanced liver disease, it might be interesting to treat them even if they are still immunocompetent. In terms of second-line treatment of chronically infected patients, he's a very old-fashioned guy because the only thing he's explained to us is that we can use PEG interferon in this setting. So we come back to the old drugs. There is no new drugs that are available in this setting. Then we move to hepatitis delta in the afternoon. George showed us the epidemiology and the changing epidemiology of HDV infections with genotype distributions. Globally, HDV infection is a global health problem. Everything is a global health problem. Is increased liver-related and overall mortality. Global HDV prevalence is probably underestimated. HDV is still endemic in many developing countries. And of course, in the Western world, now we have an increase of HDV coming from illicit drug users, people with high-risk sexual behavior, and HIV co-infected patients. In the 1990s, we were at a genuine decrease in HBV prevalence, and now there is no further decline and a slight increase which is linked to this kind of contaminations and also due to the migrations from endemic countries. So there is a need for universal HBV vaccination, and it's important to repeat this message, and a universal HDV screening for HBs positive patients. How to optimize current therapy with PEG, and Pietro goes through this issue. He shows us that the off-label use of PEG 48 weeks is currently the only recommended therapy by international guidelines. The indications is chronic hepatitis and compensated cirrhotic patients. The response rate is very low, about 20 to 30% at week 24 post-treatment, with a very high risk of relapse. The strategy to improve efficacy by combinations with nuke extensions to 6 weeks or the use of lambda interference had very mild improvement in terms of efficacy. The predictor of response early on therapy is the decline of HBs antigens and or HDV RNA needs to be confirmed. And the long-term outcome is only good in patients with sustained response. So we urgently need new anti-HDV therapies. And then Tarek goes through this new drug for HDV. He went through the current development of the entry inhibitors, the bulevirtide, the prenylation inhibitors, the lonafarnib, and the HBs antigens release inhibitors, the NAP. So there is a need for long-term robust endpoints, such as ACC cirrhosis decompensations. But already this drug gave us a very interesting response and answer in terms of short-term outcome. HBV cure program will also lead to HDV cure, but only in the long term. So clearly there is a need for the development of an HDV-specific drugs. Then we move to the award of PHC 2020, the future of autoimmune liver disease. And so that was nicely addressed by Michael Manns. And the true message of Michael Manns is you need to treat the right patients with the right drugs. New biomarkers are needed to predict non-response to UDCA in PBC. Obeticholic acids and bezafibrate are used for non-response to UDCA in PBC. The combinations of both and novel drugs like selective, like PPAR and fibroblast growth factors agonists might be a solution, but I think that the last one have been mostly stopped in development. There is no existing treatment that alters the natural course of PSC apart from transplantations. And several medical therapies for PSC are under clinical development like NOR-UDCA, fecal microbiota transplantations, and others. And however, generally accept treatment endpoint as well as biomarkers for risk stratifications are still needed for the development of novel PSC therapy. And ending with autoimmune liver disease, the therapy for non-responders to standard of care are an unmet need for autoimmune hepatitis patients. And there is promising autoimmune hepatitis therapies that are under development, and those therapies are targeting B cells, cytokine-like TNF, and interferon-like EL2 and Tregs. Then we move to PHC. PHC for just 1 hour. The eliminations. The last difficult patients to treat, macro and micro eliminations. So Stefan showed us the several challenges that we have, and clearly those challenges remain in the small populations. And most likely those populations will disappear faster than the challenges are solved. And so the key challenge to reduce the burden of the disease in geographic regions and populations is the fact that you need to increase diagnosis rate, the linkage, increase linkage to care, and increase access to DEA. Then HOLA deal with the macro eliminations problem. As you all know, WHO eliminations goal need to be reached in 2030. However, by 2017, only 12 countries are on track to reach this goal. And barrier for elimination still remain, and it's always the same thing: awareness of the infections, economy for testing and treatment, linkage to care. And reducing global burden will depend on the success of prevention, outreach, screening, and treatment and progress in key high-burden countries. And what is needed for HIV eliminations, and where are the patients, and that's all the things. So we need to treat all patients, we need to have the cheapest drugs, and we need to involve everybody. That's the main message. But currently, only 12 countries are on the track, and 84% of the high-income countries are not on track to meet the WHO 2030 targets. And the collaborative between stakeholders is essential to achieve HIV eliminations. That's always the same cartoon that we always shown, is that we need both the involvement of us, healthcare professionals, but also of national government with funding, not like in Italy without any funding, patients and civil society, pharma, and global organizations. Italy have a program with no funding. Us in France, we have no program with no funding. So we fund ourselves. Microeliminations, so Stan go through microeliminations, and what he shows is that there is at least 3 kinds of populations with increased complexity to reach. There is the easy-to-screen patients, but he shows us that even in this setting, there is still 10 to 20% of the patients that are not currently being treated. In the high risk of transmissions patients, the things become more and more complicated, especially, for example, in the psychiatric patients. And the difficult-to-reach patients is almost the patients that are always very hard to reach. And so, of course, we are all conducting microeliminations project in all nations. And I think that even if access to care, even in easy-to-treat patients may be hard, we need to be pragmatic and adopt policy at each situation and try to improve, increase the number of microeliminations projects, and that's maybe the way we can achieve macroeliminations by the end. Then the end of the day was a very nice, as usual, state-of-art lecture from Dominique Valla with very nice and clear-cut conclusions about the new advance of vascular liver disease. Dominique shows that there was no major advance, or some advance needs to be confirmed. So clearly, the important point is that if you have any congenital extrahepatic portosystemic shunts, okay, you can go forwards and go to closure. It's work, and now Dominique is convinced, so we need to be convinced. Slowing of portal blood flow parallel progressions of cirrhosis and development of portal vein thrombosis. Still, there is no threshold of velocity triggering anticoagulation. So, okay, it's work, but we don't know when we need to do something. So forget it, unless we are going to make a very nice, clear-cut trial. Non-specific beta blocker may contribute to portal vein thrombosis. Direct evidence and exact mechanism still to be provided. So no change in current practice, no change. And transient portal vein thrombosis is most common in cirrhosis. Its role as an indicator for subsequent extrahepatic extensions or a factor for aggravating liver disease require further study. So you see, the things are moving, but slowly moving in this field. That's it. So thank you very much. That's the sum up of these take-home missions over the day. Thank you for your attention, and a great thanks to all speakers who provide me their presentations. Thank you.